Yeah.
Thank you.
Okay, there we go. So anyway, it's a pleasure to introduce Per Borghammer from Aarhus in Denmark. He's going to speak today. So Per is a professor of nuclear medicine and neuroscience at his university. And his research group is doing a very impressive spectrum of work on Parkinson's and related problems, really from basic preclinical experiments up through quite an impressive body of human experimental research, and doing quite a bit of volume with PET tracers and characterization. Per has been particularly interested in a really important question in the field, which is disease heterogeneity and potential subtypes. And what I think he's going to talk about today is actually a particularly interesting proposal that he and his colleagues have made about subtyping and natural history of Parkinson's disease. So, Per, thanks very much for joining us. It's late in Denmark, so we really appreciate this.
Okay, thank you very much, Roger, for that nice introduction. Can you see my slides?
Yes.
Good. So I think I'll grab the laser pointer. Okay. So yeah, so thank you again. I'm going to talk about this idea that we have proposed, the body first and brain first model of Parkinson's disease is what the title says. But I will immediately revise that to Lewy body disease, because in this model, and in my opinion, there's no important difference between dementia with Lewy bodies and Parkinson's disease. I think it's the same disease, at least the Lewy body part of the disease is the same. So what I'm going to talk about today covers all of Lewy body diseases, including dementia with Lewy bodies. So I'll start with Heiko Braak. I think you all know him, probably one of the world's most important living neuropathologists. 20 years ago, he suggested or proposed his famous staging scheme for Parkinson's disease. And you could say that one of the important things that he kind of implicitly suggested was that Parkinson's disease can be understood as a disease where the pathology starts in one place and then spreads from there. Or maybe actually he suggested two places, the gut and the olfactory bulb. So basically what he says was the pathology starts in the gut, spreads via the vagus to the dorsal motor nucleus, up and up. Simultaneously, it starts in the olfactory bulb. But he said that the bulb is not really important because it doesn't really spread very far from the bulb. So it is the dorsal motor nucleus and so on that's the important part. And kind of in a simplified way, it kind of fits with the symptoms because some patients develop constipation before diagnosis. That probably comes from the gut, the parasympathetic innervation. Some patients develop REM sleep behavior disorder before diagnosis, which probably stems from damage to the pons. And all of this happens before the mesencephalon is involved, the dopamine system. So it kind of fits in a simplified way. However, we've known for at least 15 years that Braak's hypothesis is most likely incomplete. There's lots of different evidence to suggest that, and I'll just spend a little bit of time to talk about it. First, I just want to point out that Braak and Christopher Hawkes in 2007 proposed a dual hit hypothesis, which is basically just a natural extension of Braak's idea. And basically what they said was, in every single case, more or less, of Parkinson's disease, the pathology starts in the dorsal motor nucleus and simultaneously in the olfactory bulb. And I'm also going to talk about that because I don't think that that is correct. So first, if we simply look at the symptoms, with a view to Braak's idea, well, we notice that about 2/3 of Parkinson patients do not develop constipation before diagnosis, and 2/3 of Parkinson patients do not develop RBD before diagnosis. So this lack of symptoms actually does not really fit very well with Braak's idea. Perhaps more importantly, already a few years after Braak's paper, several papers came out. This is just one from Laura Parkin in 2008. And here they show that there was 25 cases here that did not have any pathology in the dorsal motor nucleus. And according to Braque, it should always start there. But these cases had pathology further up the brainstem and the amygdala sometimes. And obviously, these cases cannot be staged by Braque's staging scheme. So these cases are out there. And that was noticed immediately. Okay, so I spent almost 10 years doing research where I really tried hard to prove that Braque was right. And the more studies we did, the more I read, the more I realized that I think he definitely is right, but only concerning a proportion of the patients, not all of them. So on the right here, that's what we call body first Parkinson's disease or body first Lewy body disease. And this is basically what Braque was talking about, except that we stress very firmly that the spreading route via the sympathetic system is probably at least as important as the vagal spreading route. So the pathology spreads from the gut to the celiac mesenteric ganglia to the sympathetic trunk. That's how it comes to the heart very fast, and it can then spread to the locus coeruleus from the spinal cord. But the other category we term brain first Parkinson's disease. I think most of these cases, the pathology starts in an isolated fashion in the bulb, spreads to the amygdala. Sometimes it starts in the amygdala, probably, but then it spreads from there, which means that it will reach the nigra very fast. So the prodromal phase is much shorter. The patients develop dopamine loss, Parkinsonism, but at this early time point where they get the diagnosis, they don't have a lot of non-motor symptoms. They don't have RBD, but then the pathology spreads in the other direction, eventually reaches the peripheral autonomic nervous system. So at the later stages, these two types are more or less identical. There's pathology everywhere, if you will. They have overlapping symptoms. But if you look at the patients very early on, they are very different. So that's the idea. When we look at the symptoms, obviously, body first Parkinson's, these are the patients that develop all the autonomic symptoms before diagnosis, constipation, orthostatic hypotension. They develop RBD before diagnosis. Nearly all of them develop profound sympathetic denervation of the heart, so an invisible heart, if you will, on an MIBT heart scan before diagnosis. Now, on the left, brain first patients, they do not develop these symptoms before diagnosis, but they develop them after diagnosis in most cases. And if we look at the proportion, so in the top right here, about 1/3 of Parkinson patients develop RBD before diagnosis. They usually also have constipation and so on. But if we then look at dementia with Lewy bodies, probably at least 70, perhaps 80% of dementia with Lewy bodies develop RBD, constipation, and so on before diagnosis. So if we merge those two, could you?
I don't know if I have or not. I don't symptomatic.
I think someone could mute their microphone, please.
Could you please mute your microphone, guys? Sorry. Okay, so I was saying, if we merge Parkinson's disease and DLB into one group, we end up with something like 50% of all Lewy body patients develop RBD before diagnosis. 50% do not. So we use these numbers to say that about 50% of Lewy body patients are body first, 50% are brain first. And now this paper was just out a few days ago by Claudia Trinkwalder in Göttingen. So they did polysomnography in very late stage PD, Hühn stage 3 to 5, 467 patients, and 406 had RBD. So that means if you follow Parkinson patients and until very late, 87% have RBD. When they got the diagnosis, only 1/3 of them had RBD. So that's just to show that brain first patients will develop RBD eventually. If we look at the heart MIBG scans, here you can see Hühn stage 1, 50% have a normal heart. But when you reach Hühn stage 3, 4 to 5, especially 4 and 5, every single patient has an invisible heart. So this is also inevitable, again, meaning that the brain first patients will converge on the same phenotype that the body first patients show a lot earlier. Okay, so brain first and body first Lewy body disease, as I talked about, is actually just a subpart of a larger model that we have proposed that we call the SOC model, SOC, for synuclein, origin, and connectome. We believe this model, in addition to explaining the brain first and body first types, it can also explain why Parkinson's disease is an asymmetric disease. But it can also explain who among the patients are asymmetric and who are more symmetric. And it also has something to say about malignant versus more benign subtypes of the disease. At least that's the theory. So the theory of the SOC model has three parts. The synuclein part is the first one. So we propose that in most cases, perhaps in about 90% of cases, the first synuclein pathology starts in a single location and then spreads from there. So a little bit like a cancer, one primary tumor, the rest is metastasis from the primary tumor. And now the second part is, so where does the first pathology start? It can start in the enteric nervous system, and that gives rise to the body first type. If it starts in the olfactory bulb or the amygdala, rarely some other places, maybe the nigra itself, it will give rise to a brain first type. And then the connectome is important to explain the asymmetry, but that only works if we are prepared to accept the first assumption, namely that the pathology starts in a single place and spreads from there. If that is the case, then the connectome details that we know about the brain can get us a long way towards explaining why Parkinson's disease are asymmetric sometimes. So I want to point out that these models are first and foremost models of prion-like spreading in Lewy body disease. They are hypothesis-driven, not data-driven, not post-hoc. And they're based on synthesizing evidence from many different fields like clinical data, post-mortem imaging, animal models, epidemiology. And it's an a priori model, so it has testable predictions. It's falsifiable. And it's also important to acknowledge and to stress that it is definitely not the full story, because like genetics, selective vulnerability in various cells, neuroinflammation, and so on, are all important, and I think will serve to modify the disease course in individual patients. So the model is only about prion-like spreading, kind of synuclein, to see how much can we explain just looking at that. So now I'll talk about first some imaging evidence of the body first and brain first idea, and afterwards some post-mortem. So first imaging, and I'll start by a couple of slides about the sympathetic innervation in Parkinson's disease, because I think that the heart and the sympathetic innervation and the sympathetic damage in Lewy body disease is not getting the attention that it deserves, at least not with respect to trying to understand the disease. And I think I'm trying to illustrate that on the right here, because I think these curves that you see here are representative for 50% of all Lewy body patients. And the curves show that you have a patient starting at some kind of baseline, there's no neurodegeneration left, then the heart starts to degenerate, or the sympathetic innervation of the heart starts to go away. And when it's fully gone, the dopamine system is still intact. And this takes 10 years. So why would I say this? Well, because there's more than 200 RBD patients, isolated RBD, that have been scanned with MIBT. 95% of them have a very damaged heart, almost invisible, but the majority still have a normal dopamine scan. So that means your typical RBD patient is here, invisible heart, but the dopamine scan is still normal. How long time does it take to develop an invisible heart? We can estimate that from longitudinal MIBT scans or studies from Japan. And we end up with saying that it takes about 8 to 10 years to go from a normal heart to an invisible heart. Okay. So the next the next question is, how long time does it take for a typical RBD patient to convert to Parkinson's disease or DLB? And we know that with certainty from the large follow-up studies. It takes about 8 years. After 8 years, 50% have converted to Parkinson's or DLB. So that means it takes 8 years, okay? So when we look at these curves, we can ask ourselves the question, is cardiac imaging just as important as dopamine imaging, at least to understand the origins of Lewy body disease? And I would say yes, because I would claim that with the data we have now, we can say that about 50% of all Lewy body patients, these curves on the right show how the neurodegeneration goes on in these patients, with the heart starting to degenerate more than 10 years before the dopamine system, and 16 to 20 years or even longer before phenoconversion. And I think this by itself is a strong, not evidence, but it strongly suggests that the term body first Lewy body disease is not completely crazy, because the body, the autonomic system seems to degenerate very, very early before major degeneration in the brain. Yeah, I'll return to that. Okay, so more on imaging. So this is the hypothesis that we use to test whether brain and body first exists when we just use in vivo imaging. The hypothesis is this: if we can find very early brain first cases, well, they are brain first, so we would expect them to have damage to the brain, for instance, a damaged dopamine scan, but the body should still be normal. So the heart scan should be normal. Cholinergic innervation of the gut, which we believe is a marker of the sympathetic innervation, should be normal. Now, the complete opposite pattern should be seen in very early body first. They should still have a normal brain, perhaps at least a normal dopamine scan, more or less, but the body should show damage, an invisible heart, and decreased cholinergic innervation of the colon. And this is what we found. So in the top right corner, you have healthy controls. They are normal on both scans. They have normal dopamine, so they are to the right. They have a normal heart, so they are up here at the top, so they're in the top right corner. The blue patients are body first. They had RBD before diagnosis. They start by going down, losing the heart first, but they are to the right here, so they still have a normal dopamine scan in the case of the isolated RBD patients. Once they develop Parkinsonism, well, then the dopamine scans are also pathological. Now, the red patients are the opposite, brain first patients. They are de novo Parkinson's disease without RBD, very little non-motor symptom burden, no constipation. They first move left, losing the brain or the dopamine system first, but many of them have a normal heart or near normal heart. And then later they start to move down, and they will also end in this bottom left corner here when we follow them up, as we are doing. On the right, this is the same idea, but now on the y-axis, we have the cholinergic innervation of the colon. We see the same pattern. Most of the brain first patients are here with a normal colon. Most, like the controls, most of the blue body first patients also have decreased cholinergic innervation, which we believe is a marker of parasympathetic deficit. Okay, so that was the imaging data that seems to support these two subtypes. Now, what about postmortem? So, if we look at a postmortem brain, typically of a Parkinson's disease patient or DLB, well, they are already in Bragg stage 5 and 6. So it looks something like this. There's Lewy pathology in all of these places. So if we use kind of a fire in a house analogy, we have this apartment building. Well, I mean, the fire has spread everywhere, so we don't really know where the fire started. So we need to go early. We need to study only incidental Lewy body disease cases. They don't have the diagnosis yet, but they have very limited and restricted Lewy pathology, because in analogy, well, if the fire has gone out and there's only a couple of rooms where it has spread to, well, we had a pretty good idea, at least approximately, in which room the fire started. So that's the thinking of these studies. So I've been looking at 3 different fairly large post-mortem data sets, 2 from Finland, 1 from Japan. All of these cases were Lewy body positive. You can see 528 cases in total. But then I only focused on those with very limited pathology because of the burning house analogy I said before. So I only focused at 155 cases that had the most limited pathology. And this is by far the largest analysis of such early stage ILBD cases that has been done so far to my knowledge. And when we do that, we see very clearly, in my opinion, that there's 2 main categories. In one category, the pathology is at the bottom of the brainstem, the spinal cord, and the peripheral autonomic nervous system. But there's nothing in the bulb, there's nothing in the amygdala. The other category, you see pathology in the bulb, the limbic system, in the top of the brainstem, but there's nothing in the dorsal motor nucleus, nothing in the spinal cord, and nothing in the peripheral autonomic nervous system. So this is the Japanese data, and here you can see this is my own Excel sheet. So this is every single case profile that's in the database. And you can see I focus only on cases with pathology in 1, 2, 3, or 4 anatomical regions. And here you can see that there are cases with pathology only in the red and the blue and the yellow, like this, only in the red, that's here, and yellow, but nothing in the blue. These cases here have only pathology in the blue and yellow, but nothing in the red. And then there were 7% of cases that did not fit, 7%. Now in the Finnish data set, red and yellow, like this, blue and yellow, like this, and 5% of cases didn't fit. And then the final Finnish data set, another independent data set, red and yellow, blue and yellow, and 8% didn't fit in these categories. So that means a very rough number, we would say there's a 50-50 distribution between these 2 categories, but the exact numbers across these 3 data sets are 46% of cases look like this, 47% of cases look like this, and then there's 7% of cases that don't really fit. But it means that these 2 categories are the rule and the strange cases are the exception. So at the beginning, I said that the dual hit hypothesis by Bragg and Hawkes stated that in every single case, the pathology starts in the DMV and the olfactory bulb at the same time. But what I just showed you doesn't seem to support that. It rather supports an either-or scenario. Either the pathology starts in the gut, perhaps, or at least it is in the parasympathetic and sympathetic system early, not in the bulb, or it is in the bulb and the amygdala early, but then it's not in the autonomic system. Because that is what the data looks like, the data I just showed you in 93% of the cases. But there were 7% of the cases that actually might be true dual hit cases where you see early pathology in the bulb, the autonomic system, but not really anything in between. Yeah. And by the way, these numbers are one of the reasons for why I propose that in the majority of cases with Lewy body disease, it might be okay to say that this is a bit like a cancer, starts in a single place and then spreads from there. But in rare cases, you can have a multifocal onset. And if we look at cancer, 90% of cancers are unifocal, only one primary tumor, but then about 10% actually have more than one primary tumor. And it's not to say that PD has anything to do with cancer, but it's just an analogy. Okay, so I already showed you this. This was when I talked about the distribution of clinical phenotypes. About 50% seem to have a clinical phenotype of body first, based on their RBD and so on, 50% brain first. When we look in the post-mortem literature or data, there seems also to be a 50% distribution, more or less, between the brainstem predominant and the limbic olfactory predominant. So these 2 proportions of 50-50 seems to fit quite well. And this is something, this is the last slide on postmortem, I think. This is something I've just started to work on. So this is completely fresh data, unpublished. So here I look only at the Japanese data set, 180 cases, and then 120 cases from Newcastle, because these two data sets are special in the sense that they have data from the peripheral sympathetic system, from the sympathetic ganglia. So this is the peripheral nervous system. So the question is here, which place is the most common to see the very first pathology in postmortem? Is it actually the DMV, or might it be actually the sympathetic system? And when we look across these 300 cases, we see that there's only 2 cases with isolated pathology in the DMV, but nowhere else. But there's 14 cases with isolated pathology in the sympathetic system, with pathology nowhere else. What does this mean? I think it means that Lewy pathology starting in the gut spreads perhaps faster and more readily via the sympathetic spreading route to the sympathetic trunk. And it might remain there for a little bit of time. So in a cross-sectional data set in postmortem, it's statistically more likely to find isolated sympathetic pathology compared to isolated DMV pathology. And this underscores the importance of the sympathetic system and the sympathetic spreading route. Now, on the left here, my colleague Natalie Vandenberg is doing all the animal work in our group. And when we inject synuclein seeds into the gut of rats, we see very fast spreading of pathology. This is the celiac ganglion, and there's massive amounts of pathology. It's one of the places anywhere in the nervous system where you see most pathology. And the same is actually the case in human postmortem data. There's a very striking pathology in the sympathetic ganglia, also in humans. So this system is very prone to form a lot of Lewy pathology, and it's also very prone to degenerate. Okay, so now on to 3 predictions of the SOC model. So the first prediction of this model is that it is able to explain non-motor subtypes, body first and brain first. And I only need to show you one fast slide because I already explained this previously. According to this model, we would expect to see a subtype where you have all of these autonomic symptoms and RBD and so on before diagnosis, before dopamine loss. And you would expect to see another type where you see all the same symptoms and signs, but they come after diagnosis. And we already know from the imaging and the clinical literature that this seems to be the case. Now, the second prediction is about motor asymmetry. And here the model predicts that body first patients are more symmetric, whereas brain first are more asymmetric. And to explain that, we first need to look at the connectome, because in the mammalian brain, 99% of the connections remain in the same hemisphere. One hemisphere speaks mainly to itself. Only 1% of the connections cross to the contralateral hemisphere. And this has been shown in countless neurotracer studies from the old days. For instance, like this one from 1990, you inject horseradish peroxidase in the amygdala of a cat, then you count the connections, and you see that approximately there's 100 times more connections in the same hemisphere compared to the other hemisphere. So this is not controversial. Now, the second point of the connectome is that when we look at the autonomic nervous system, there seems to be a weird overlap in the gut, in the sense that the left and the right dorsal motor nucleus, and probably also the sympathetic system, seems to show left and right overlap. So this means that if pathology starts somewhere in the gut, it might spread more symmetrically to both the left and the right side of the central nervous system. Okay, so if we first look at brain first disease, and remember the first assumption in the SOC model is that this is like a cancer, it starts one place, spreads from there. Well, then if it starts in one olfactory bulb, not both of them, but just one, or if it starts in one amygdala, well, because of this extreme lateralization of the connectome, it will remain statistically in the same hemisphere, more so than spreading. So it'll reach the same-sided nigraph first. it'll start to degenerate first. So these patients show up with an asymmetric dopamine scan and asymmetric Parkinsonism because of this lateralization. If we look at animal work, again, this is from my group, if we inject rats into one amygdala with synuclein seeds, wait for 1 month, we see nice Lewy-like pathology in the same-sided nigra. At this early time point, there's nothing in the other side. This is from Takahashi in Kyoto. This is primate data. If they inject synuclein into one olfactory bulb, they see mainly ipsilateral spreading to the amygdala and also the nigra, much more so than spreading to the other side. So these animal studies seems to support the idea. Now, what about body first? Remember, as I said, if the pathology starts somewhere in the gut, and there's a left-right overlap to a certain extent, it will tend to spread to both the left and the right side of the central nervous system. So very early on, you see more symmetric pathology in the left and the right DMV, and probably also in the sympathetic system. So now it doesn't matter anymore that there's this 99% lateralization, because it's more symmetric from the onset, meaning that it will reach the nigrum in a more symmetric fashion. It'll start to degenerate. So body-first patients should show up with more symmetric dopamine loss and more symmetric Parkinsonism compared to brain-first, on average. Again, animal work, every time we inject synuclein seeds into the gut of rats and mice, and it's the same in all the other studies I've ever seen, that we tend to see very symmetric spreading. This is the dorsal motor nucleus, completely symmetric pathology, and it's also symmetric when it spreads further up the brain. Now, we tested the idea in human data. This is dopamine scans, and on the y-axis, this is an asymmetry index. So here you have healthy controls. They have symmetric scans because they are normal. They are symmetrical. Here you have de novo body-first patients. They also, most of them have symmetric scans, but that's because they have lost both of the putamen, more or less. Whereas a lot more of the early brain-first patients have much more asymmetric scans. They have mainly lost the innervation in one putamen more than in the other. And again, animal work, when we inject in the gut of rats, 8 months later, using micro-PET scans, we see symmetric loss of the dopamine system. If we inject into just one amygdala, 8 months later, we see mainly asymmetric loss in the same site as we injected. Sorry, that's down here. This is the rat scan. And all the animal work is done by my colleague, Natalie Vandenberger, so I want to acknowledge that. Okay, so moving on to the final prediction, a little bit about malignant and benign types of disease. And the prediction here, or the prediction, I guess you could say, is that body-first disease gives you kind of a more faster progressive phenotype, faster dementia, compared to brain-first. So there's many studies have come out over the last years looking into, cluster analysis of large numbers of PD patients, and then they divide them into benign and malignant disease and intermediate groups. And what they find is always that the malignant group, these are the patients with fast progression, fast dementia. These patients generally are older. They have RBD, constipation, orthostatic hypertension, more symmetric disease, and pathological MIBG heart scans. So this basically is the full body-first package. So that's why one of the reasons for why we say it seems like body-first disease gives you a more malignant and phenotype with faster dementia. If we look at dementia with Lewy bodies, and dementia with Lewy bodies is definitely a more malignant form of Lewy body disease compared to many Parkinson patients. If we look at early dementia with Lewy bodies and compare them to matched early Parkinson's, early DLB have more autonomic symptoms, much more frequent RBD, more frequent orthostatic hypertension, more symmetric motor disease, and they nearly always have a pathological MIBG heart scan. Again, it's the body-first package. So we would expect that DLB patients also have more symmetric dopamine loss. And we just published that. Here you see 30 DLB cases, de novo, newly diagnosed. 80% of them have quite symmetric loss of dopamine, compared to 80 de novo Parkinsons, where 60% of the de novo Parkinsons have much more asymmetric scans and only 40% have more symmetric scans compared to DLB. So that again supports that DLB has more of a body-first type. Okay, so why would we think that body-first Lewy body disease gives you faster dementia? I don't know, but this is speculation. This is the hypothesis. So according to the model, we would think that at the time of diagnosis, we're talking about Parkinson patients now because we base the diagnosis on Parkinsonism. So we basically base the diagnosis on the dopamine system. At this time point of the disease, the pathology in body first looks like this, whereas in brain first, it looks like that. Why? Because in body first, it comes from downstairs, climbs up through the brainstem, and it's symmetrical. Whereas in brain first, it comes asymmetrical via the amygdala olfactory bulb, and it hasn't really spread a lot to the brainstem yet, compared to body first. And there's also asymmetry, so there's less in the contralateral hemisphere. So in body first, these patients have much more pathology in the brainstem at diagnosis, and it's symmetrical. In the brainstem, we have all of these neuromodulatory systems, the nigra itself, the PPN, the raphe, the locus coeruleus, the nucleus basalis of Maynard in the basal forebrain. So if you have damage to all of these systems bilaterally, I think that this can contribute to subcortical dementia. Moreover, these systems, if you think about the architecture, these systems are perfectly distributed to send synuclein pathology everywhere in the brain, because that's what these systems do. They innervate the entire brain. And in body first, at diagnosis, these systems show a lot more damage, and it's symmetric, I think, compared to brain first. So this might be another mechanism that will promote very fast cortical Lewy body disease in body first compared to brain first. Yeah. Okay. So in the last 2, 3, or 4 minutes, something like that, I will talk, a little bit more about dementia. And then one more thing, I think. So when we talk about dementia, so in the last slide here, the final point here was that body first Lewy body dementia is in itself kind of a malignant phenomenon that gives you faster dementia, perhaps because of this explanation. But at least when we look at the clinical literature, it seems to be, body first patients seem to have a much higher risk of fast dementia. But it's also extremely important to look at Alzheimer's co-pathology, and we've known that for a long time. And this is a very nice meta-analysis done by your group. Perhaps we need a new one because it's already 7, 8 years old, but I think it's still very valid. So that meta-analysis showed that patients with DLB, 68% had comorbid Alzheimer co-pathology. Patients with demented or PDD, about 1/3 have had Alzheimer co-pathology, but in non-demented PD, only 5% had Alzheimer co-pathology. And several postmortem studies have shown the same. DLB, 66 up to 80%, PDD, about half of the patients. So clearly, Lewy body patients that are demented have much more Alzheimer pathology compared to Lewy body patients that are not demented. Okay, so based on these two things, I propose the following way to understand dementia in Lewy body disease. So first, we can look at the Lewy body axis or the Lewy body dimension. And here it seems like body first is worse than brain first, okay? But then there's also an Alzheimer co-pathology axis. And if you have Alzheimer co-pathology in intermediate or high amounts, that's also bad. So that means that a patient that has body first Lewy body disease and just happens to also have Alzheimer co-pathology will very often receive the demential Lewy body diagnosis rather than a PD diagnosis, simply because this patient has two pathologies and each of them promotes fast dementia. Now, on the contrary, if you have brain-first Lewy body disease and you don't have Alzheimer's co-pathology, these patients will always get the Parkinson diagnosis, and this is the more classical earlier onset Parkinson patient, asymmetric scan, no RBD, not a lot of non-motor symptoms. These patients will, it'll take many years or decades before they become demented. And then the patients in the two other quadrants will have quite kind of in-between progression rates, slower than this corner, but faster than this corner. And finally, if we look a little bit at genes, GBA mutations seems to be associated with a body-first phenotype. They have more RBD, they have faster progression. But GBA is not associated with Alzheimer's disease. So GBA might be associated with the body-first Lewy body dimension, and that's why it's associated with dementia. Whereas, well, if we look at ApoE4, that is mainly associated and strongly with Alzheimer's co-pathology. So ApoE4 is also associated with PDD and DLB, not so much because of any association with Lewy pathology, but because it promotes the Alzheimer's co-pathology. On the other hand, LAG2 seems to promote a more benign, slow progressive disease, rarely RBD. So LAG2 does not show up in the studies I mean, there's no association with demential Lewy bodies or Parkinson's disease dementia, because it is associated with a more benign brain-first type. Anyway, this is speculation, but I think it's an interesting hypothesis that can be explored. And then finally, the last two slides here, as I'm sure you are all aware, that we are kind of at the start of a new era, perhaps, because now the suggestions, the papers are coming out that suggest a new biological definition of Lewy body disease. And this is one of the suggestions. This is from the MDS group. So they suggest that in this biological definition, a patient should be synuclein positive and neurodegeneration positive. Then you have biological evidence of Parkinson's disease, okay? That's what you need. This table 5 is about the symptoms. And my point here by showing this table is that they don't give any special significance to the dopamine system. So the symptoms could be motor or hyposmia or dysautonomia or RBD or cognitive or affective. It doesn't need to be motor. You just need one or two of these. So this system says that DLB and Parkinson's disease and pure autonomic failure, etc., is all the same Lewy body disease. So if we take that, and by the way, I completely agree with this, and I've been saying this myself for several years. So if we fuse these two into this cartoon here, we can say at the preclinical stage of Lewy body disease, well, you are S positive, you might have a little bit of neurodegeneration, but not enough yet to give you symptoms, so you're preclinical. Well, it seems like it could be that the pathology starts in either in a brain-first or a body-first manner in most of the cases, and then maybe 7% or 10% in kind of a more mixed multifocal onset. Then the body-first cases will usually develop RBD first with pathology to the sympathetic, parasympathetic, and locus coeruleus. Rarely, it will show up as the pure autonomic failure clinical type with sympathetic and parasympathetic damage. Pure autonomic failure very often goes on to develop Parkinson's or DLB, but before they do, they nearly always convert to RBD first. So they go to RBD because of the ascending pathology. RBD then becomes Parkinson's with RBD, or it goes straight to dementia of Lewy bodies. And of course, Parkinson's disease with RBD goes also to Lewy body dementia. Now, brain first goes more directly to Parkinson's without RBD, but as we saw, most patients will eventually develop RBD and then they will dement. Sometimes they might go straight to dementia. And finally, there's a smaller fraction of patients that might have no Parkinsonism and no RPD, but they might have other symptoms like hyposmia, anxiety, psychiatric symptoms, maybe MCI, but without Parkinson's, without RPD. These patients might then develop Parkinson's disease, or they might go straight to MCI and then Lewy body dementia. And one of the points of this schema here is at the early and moderate clinical stages, these patients are very heterogeneous with different neuropathology, different neurodegeneration, different symptoms. And that is why we, over the years, have given them different diagnostic labels. But they all seem to converge with time on a more advanced end stage, demented stage, where we know from imaging that they have pathology and neurodegeneration everywhere. That nearly all of them have RBD, nearly all of them have Parkinsonism, nearly all of them have autonomic symptoms, and nearly all of them are demented. So they converge on an advanced stage that is much more homogeneous than these clinical early stages. Yes, so I think, yeah, I had a couple of more slides, but I think in the interest of time, I will stop there, and thank you very much for your attention.
Excellent, thank you. That was an excellent presentation. Just to, I'm sure people will have some questions, but let me start off real quickly. So really, your explanation for why the body first proceeds sometimes to dementia with Lewy bodies as a phenotype and sometimes to more typical PD would really be the associated amyloid pathology, and it's kind of a selection effect. Is that a fair characterization?
So I'm very sorry, Roger. Could you repeat that? I was
so your explanation for why some body first proceed to a more typical PD phenotype versus the dementia with Lewy bodies. The dementia with Lewy bodies group has the associated amyloid pathology, so it's kind of a selection effect there.
Yes.
Is that a fair characterization? Okay. Yeah.
Absolutely. I think yeah. Okay. If I may elaborate just a little bit. Yes. Mm-hmm. I think so. I think that if we kind of forget about the clinical diagnosis first, and then we just think about, okay, right, if we have an individual that just happens to have body first Lewy body disease and comorbid AD pathology, that person is much more likely to develop much faster dementia, such that we will recognize the person as a DLB case. Right.
Exactly. Yeah. But no, I think that's very plausible. I guess I would actually amplify that because, as we now know, there are other age-related pathologies that accumulate in the brain. So, TDP-43 pathology, tau pathologies, and all of those could be contributing to that. And I think that's partly the explanation for why these older subjects are the ones who seem to have the more malignant course frequently, partly because of the age-related pathologies. I guess I'll just add the one comment that talking about ApoE4, Tom Montine has suggested, it's presented some data that actually ApoE4, while it doesn't increase your risk for PD, it does seem to accelerate the dementia, and it may actually impact the amount of the magnitude of synuclein pathology in those individuals. So that, now whether it's a selection, the other alternative explanation for this, cross pathologies, there's actually some cross seeding, and having one pathology, increases the generation of the other. So that's equally speculative. That's quite speculative as well. And I have to say, I like your model better. So,
well, thank you for saying that. But I said before that I wanted to elaborate a little bit, but then I didn't, because what I wanted to say was exactly what you just said. Mm-hmm. So I think that both these phenomena are in play. I think, first of all, there's simply the simple selection thing that we talked about. So and that works even if Lewy body disease and Alzheimer's pathology is completely independent. Right. But I don't think they are. I think there is cross-seeding. There's several studies to show it. And there's another interesting observation that I'm trying to publish now. I don't think anyone has seen it before. If you look at very early, if you remember the postmortem data I showed you, mm-hmm. the very early brainstem predominance, so that's the very early body first, they have the same amount of Alzheimer's pathology as the background population. So no increase. But the very early brain first, with amygdala pathology,
Mm-hmm.
they have quite a bit more Alzheimer pathology
Mm-hmm.
than the background population. Okay, so that's how they start. But then if we then go forward and then we look at the end stage, where you have Braak stage 5 and 6, on average, not everyone, but almost everyone have more pathology than you would expect.
Mm-hmm.
You can't say it that way, but you would expect maybe if your patient group is 75 years of age at death, you would expect that maybe 30% would have Alzheimer co-pathology if they were the background population. But in reality, it's 65%.
Mm-hmm.
So that suggests to me that especially in the body first category, as the Lewy body disease evolves, it simply induces comorbid Alzheimer co-pathology. Perhaps the brain is so stressed, the homeostatic mechanisms in the cells are so stressed that they cannot fight off the Alzheimer co-pathology anymore. So it becomes more statistically likely that it also accumulates.
Right. So I think that's quite plausible. And it wouldn't necessarily have to be cross-seeding. It could just be some slowdown in proteostasis. So yes, yeah, absolutely. I think, Nico, go ahead.
Actually, I have, I believe, 4 questions, and I don't want to hijack the time of other people going to ask questions, and I can email them to you as well. But first of all, I was really impressed by your talk, and thank you for all your pioneering efforts in this important field. So you did not mention alpha-synuclein deposition in the skin, and how this relates, let's say, to body first Parkinson's disease, Lewy body disease, and what is the timeline, let's say, from post-mortem studies? What is your knowledge? Because it's my understanding, it may be present also 20 years before you have any clinical phenoconversion, and that the intriguing question is, those are also present on somatomotor, let's say, non-autonomic nerves in the skin. So how do you build in the skin deposition of alpha-synuclein in your theoretical model?
Yes. Okay. Thank you for that. That's an important question, Nico. Okay. So my suggestion is the following. There's several not only post-mortem, there's post-mortem studies, but also skin biopsy studies that show that a lot of the synuclein pathology in the skin co-localizes with sympathetic nerve fibers. So it is in the sympathetic nervous system to a large extent, perhaps to only there, as far as we know. So what I think is, if the pathology starts in the gut, and as I showed you, it spreads like wildfire through the sympathetic system. So it spreads to the celiac mesenteric ganglia, then it spreads to the sympathetic trunk. That's how it comes to the heart. So it comes to the heart via anterograde spreading from the sympathetic trunk, from the stellate ganglia. And if it can go to the heart via anterograde spreading, well, then it will also spread to the skin in anterogradely. So basically, when your sympathetic trunk is filled, not only filled, but as soon as you have pathology in the sympathetic trunk, you'll start to see synuclein pathology everywhere where you have sympathetic innervation because of anterograde spreading. And this phenomenon obviously is much more evident in early body first disease. And there is several skin biopsy studies from living patients showing that if you have RBD early, you have a lot more skin pathology than if you don't have RBD early. So it is, and especially the pure autonomic failure patients, they have most, and they have this very striking, very aggressive early body first type. So I think that is the explanation.
Okay.
But a final interesting point that I want to explore with some epidemiologists is that theoretically, toxins that might be able to cross the skin barrier, there are such toxins. If they can do that and get into contact with the sympathetic innervation of the skin, they might induce synuclein pathology. So it is even possible that some PD cases are actually started in the skin. That's completely speculative, but I think an interesting idea.
Yeah. So Per, you also mentioned the intermediate nucleus in the spinal cord, and let's say low cervical, high thoracic, and then earlier in the talk, you also mentioned the celiac ganglion. I know you mentioned the stellate ganglion, which is the, let's say, related to the intermediate nucleus. So which one is the first of those areas to be transfected by alpha-synuclein coming from the gut?
Yeah, well, that is an anatomical question, and I don't know, because, I mean, first of all, nobody knows if the pathology actually starts in the gut. I don't know. I think using Occam's ratio that is the most likely explanation. Okay, so if we accept that, then where does it start? Nobody knows. I think it can start in multiple places. I think the colon is probably the most likely, because it's very thin. There's the microbiome is there and so on. So it's more of a toxic environment, perhaps. But anyway, my point is, if it starts in the upper gastrointestinal tract, it will spread to the celiac ganglion. It will reach the heart faster because it will reach the upper part of the trunk. Whereas if it starts in the bottom of your colon, well, then the pathology will spread to the lower mesenteric ganglion and enter the lower part of the sympathetic trunk. And by the way, it might also spread to the parasympathetic plexus and the IML of the sacral spinal cord.
Mm-hmm.
Okay.
But I think it's important. I'm pretty sure that the sympathetic trunk, the postganglionic sympathetic neurons in the trunk and the ganglia are so prone to this pathology. I think it spreads pretty fast through that network. Plus, we know that in the sympathetic trunk there's a lot of cross innervation. So a single level in the sympathetic trunk sends a lot of axons up and down, so it can fairly quickly spread up and down in the trunk.
Okay. Yeah, I have a few more questions, but I have to acknowledge the time for the other people who want to ask questions, but I can email you about them.
Thank you. Any other questions for Per? So,
I mean, I can stay around for a little longer if people have questions. So just want to say that.
Yeah, I mean, if we can stay a few minutes more, we can actually.
Well, Nico, go ahead. Ask another question or two then.
I mean, the two questions and then I'm done. So let's say you use a binary system to call MIBG scans positive or negative, but we have done C11 hydroxyephedrine PET, noradrenergic transporter type 2 PET scans, where we can actually map out within the left ventricle the areas mapping out to the severity of Parkinson's disease. And there is a gradient, similar like you have a gradient of the innervation in the nigra and the striatum. We also found a nigra that starts out in the anteroseptal regions, then spreads more to the posterior and inferior walls and spares the apex. Yep. So what is your understanding from spec studies from MIBG, how much early phase scans do we call normal that are on spec with MIBG when you look at the proximal valvular plane are technically abnormal? So in other words, is it percentage even higher?
Well, surely. But I want to stress that I actually don't treat MIBG in a binary fashion, not at all. I know that when I gave a talk like this, because I like to talk about the invisible heart because it's so striking, and that kind of gives the impression that I'm actually doing it binary, but we aren't. We are measuring a continuous variable, so what we see in the vast majority of the body first patients, we simply see an invisible heart. So, I mean, it's severely pathological. In the brain first, we either see a normal scan, or we see, slight to moderate pathology, but we can still see the heart. It's still there, or at least part of the heart. Yeah. It's not completely invisible. But I mean, there's no doubt that if we use PET, 3D PET, that we would be able to get much more detail about, as you say, the progression of denervation patterns, as shown by yourself and by and by David Goldstein and so on. And we will start that next year because we will stop using MIBG and we'll convert to the PET version MFBG, which gives striking images. So we will convert all of our scans to PET from next year.
Okay. Then my last question is, you mentioned between an abnormal MIBG scan and an abnormal striatal DET, dopamine transporter PET scan of the brain, there's about a 10-year lag. But you also know from longitudinal DET SPECT scans in patients with idiopathic REM sleep behavior disorder, is you see the early phase, they start to lose dopamine more diffusely globally across the putamen and the caudate.
Yes.
And then, let's say the third scan, they show a denervation gradient, either left or right, either posterior more than the caudate, and as you have shown, the caudate more than the putamen. But there is this transitional period where we don't see either the asymmetry or anterior to posterior denervation gradients, and where we see this more accelerated loss that looks more like an accelerated global loss. Do you have any estimates of the time that you go from a completely normal scan to the denervation scan, but have this transitional period of an accelerated global striatal loss?
Not really. I think it's a good point, Nico. First of all, part of the body first idea, and I showed you some of our data that supports it, is that when you start with RBD, you will end up with, on average, a more symmetric denervation compared to brain first. And that's what we see in the majority of cases, I think. Another part of that story is that we also, the body first, you also see faster degeneration of the caudate compared to the putamen. And because we have known that for 20 years, that in DLB cases, de novo have much lower caudate compared to the putamen if you compare them to PD cases. And we just published a paper last year, this year, showing that again, that the DLB patients, and 90% of our DLB patients had RBD before diagnosis, they show up with much more caudate damage compared to the classical Parkinson patient without RBD. So we know these things, I would say, and we also know from the follow-up studies that if you take a random RBD case, in 8 years, there's a 50% probability that this patient has converted.
Yeah.
But I don't think we know for sure yet. Maybe we don't have the resolution. Maybe there haven't been done enough high-quality dopamine PET studies of RBD, where you have actually followed single patients from a clearly normal baseline and then all the way to conversion. I'm not aware of a single study that have done that.
Well, that's actually an experiment that we proposed about 20 years ago, and we could never get funding for. So.
Are you aware of any fluorodopa PET scans or fluorodopa PET scans in RBD?
Yes, I am, because my colleague Nicola Pavesi did one in Aarhus, and also with follow-up. But it was, and they had PK 1195 as well, so it was published in Lancet Neurology, and very nice. But I think the dopamine part of that study was perhaps not so strong, because most of the patients came from Iranzo's cohort in Barcelona. They were flown to Aarhus. And I think these patients, that they had them in the sleep clinic for a number of years. So I think many of them were actually quite close to conversion. So I think they were not representative if you go to the newspaper and you recruit brand new ones, if you know what I mean.
Yeah.
But I just wanted to say that we, for the last 3 years, we have used 18F P2I, this relatively new dopamine transporter ligand. That in my opinion, it's the best dopamine imaging marker in existence. It is exceptionally good And we are following RBD cases now with this tracer, but we will need another 5 years probably before we can answer your question.
Yeah, but the unique advantage of fluorodopa, it's very nice to see upregulation. So I think that there will be early upregulation after this cardiac sympathetic denervation. There's actually dopamine synthesis upregulation, and the DET scans shows you more the downregulation.
Yeah. Yes, I know, yeah. but I agree. But so then it depends on your research question. Which
indeed, yeah.
I agree.
Excellent talk. I really was impressed, and thank you
for
working.
Okay. Any other questions for anyone else, Julia? Looks like you have.
Well, I actually have a question about the asymmetry, because I'm really interested in that part of your theory, because actually we did I think you also already saw the results from my colleague. We tried to check the asymmetry in Parkinson's disease patient with and without IRBD confirmed with polysomnography, and we weren't able to actually see a difference in the asymmetry index. So I was thinking, I don't know what you think about that, but do you think can be also a matter of like the velocity of the disease progression? So you are kind of already, when you have the body first, you are kind of checking the patient where they have the pathology since a longer time. So it might be that some cases you have a more spread disease because the disease is there for a longer time, but it's not that easy to to have this difference, because I don't know how to explain it.
Yeah, well, neither do I, at least not in any robust fashion. I think, well, I mean, we obviously we could be wrong. The theory could be wrong, and the data that we produced so far might be wrong. So I acknowledge that I don't know, but another possibility is that what we're doing in my group, we are intensely focused on this question. So when we recruit our patients and the scans that we are doing and so on, and also we are very, very strict about the polysomnography, and I have 2 different experts reading it, and because we want to be as sure as we possibly can that we can say RBD negative, RBD positive, and so on and so on. So I think there's something to be said for that. I'm hoping that other groups will start to look at this in freshly formed new RBD cohorts and the earliest stage of Parkinson's disease, and then use polysomnography, because we have started a new cohort now, and we have included the first 25 patients, and we want to go up to 100. So these are de novo Parkinson's, and we do a new trick here that nobody has done before. When we, because in the first studies we've done, when we say, I would like de novo Parkinson's, then I go to my neurologist, and I trust the neurologist, and of course, that's fine. But then the neurologist say, Pierre, here's a nice de novo patient for you. And then I say, okay, good, that's a de novo patient. But in this new study, we don't trust that anymore. I mean, I trust my neurologist, but what we say is, okay, the patients are coming, but we only recruit those, then we do the dopamine scan first.
Mm-hmm. Yeah.
And then we only do those, we only include those that clearly have the most normal dopamine scans. We don't want those that have already too much, because then, what does de novo mean when you ask a neurologist, right? But you cannot argue with the PET scan when we have a large healthy control material that we can compare to and calculate set scores. So now we do that, and we're up to 25, and the data we're seeing when we do it like that is even more clear than we've seen before. So we see the most beautiful correlation between the asymmetry index. The asymmetry index in your brain scan correlates beautifully with the heart uptake. So the more asymmetrical you are in your brain, the more normal your heart is. And we have a p-value with 6 zeros or something, and we have only 25 cases. So if we go up to 100 and it still looks like that, it would be extremely striking. Yeah. So I don't know if I know. So
yeah, no, I get it.
So I think the devil is in the detail in some of these studies that have problems with showing the same thing.
Right. Okay, well, I think we're gonna bring down the curtain there, and I think, Per, thank you so much for really an excellent talk and your willingness to answer a lot of questions in the evening. So much appreciated. So
yeah, thank you very much for inviting me, and have a nice day.
Yeah, same to you. All right, thanks so much.
Bye.
Nancy, you and I are going to stay on for a minute, right?
Yeah. Roger, will you stop the recording?
Yeah, I'll stop that right now. So. Okay.